Welcome to Module 14, where we focus on a lesser discussed but clinically significant topic, hypergranulation tissue. In wound care, we often celebrate granulation tissue as a sign of healing. But what happens when this growth goes into overdrive? That's where hypergranulation, sometimes referred to as proud flesh, enters the picture. Let's delve into why it occurs, how to identify it, and most importantly, how to manage and prevent it effectively. By the end of this module, you'll be equipped to define hypergranulation tissue and distinguish it from normal granulation. Understand the underlying cellular and physiological processes that lead to this condition. Identify risk factors, complications, and the anatomical areas where it's most likely to occur. Apply both preventive and evidence-based therapeutic interventions. Educate and guide patients and caregivers for better wound care practices and outcomes. This knowledge will empower you to not only treat hypergranulation, but also to anticipate and prevent it, thus improving healing times and patient comfort. To understand hypergranulation, let's revisit granulation tissue, which is the red, moist, bumpy tissue that fills a wound during the healing process. It's rich in new blood vessels, fibroblasts, and collagen, essential components for tissue repair. Now, when this granulation tissue grows excessively and rises above the level of the wound bed, it forms a bulbous, raised mass. This is hypergranulation. Think of it like overwatering a plant. While water is essential, too much of it can lead to root rot. Similarly, too much granulation can impede the final phase of healing, epithelialization, by physically blocking the skin cells from migrating over the wound. Often, it's not painful and not infected, but if left unchecked, it can prolong healing and even become a site for secondary infection. To understand hypergranulation, it's essential to recognize how it differs from normal granulation tissue. Normal granulation is a sign of healthy wound healing. It appears red, moist, and level with the wound edges. Its texture is generally firm and resilient, and it provides a supportive base for new epithelial cells to migrate and close the wound. In contrast, hypergranulation tissue looks raised, red or pink, and often takes on a mushroom-like or bulbous appearance, sometimes spilling over the wound margins. It tends to be soft, friable, and bleeds easily, making it vulnerable to further trauma and secondary infection. Functionally, while normal granulation facilitates healing, hypergranulation hinders it by creating a physical barrier that blocks the migration of epithelial cells, preventing proper wound closure. Clinically, this means that while normal granulation is desirable and needs to be preserved, hypergranulation often requires active intervention. A practical clue: if the tissue looks like it's bulging above the wound bed and appears excessively moist or shiny, you're likely dealing with hypergranulation. Early identification is key. Recognizing the signs early allows for timely treatment, helping to restore an optimal healing environment and avoid complications down the line. So, what actually causes hypergranulation at the biological level? It primarily results from an imbalance between tissue formation and skin regeneration. Here's a breakdown of contributing factors: chronic inflammation. Prolonged inflammation leads to ongoing fibroblast activity and unchecked capillary growth. Excessive moisture. Overuse of occlusive dressings or inadequate moisture balance can create a soggy environment, promoting tissue overgrowth. Mechanical friction or pressure. Constant pressure or repetitive trauma, like rubbing from dressings, movement in joints, or suction from negative pressure therapy, can stimulate unnecessary granulation. At a molecular level, elevated levels of VEGF, vascular endothelial growth factor, and TGF-beta, transforming growth factor beta, fuel capillary overgrowth. Fibroblasts are overstimulated, producing collagen and extracellular matrix beyond what's needed. Meanwhile, keratinocyte migration stalls, delaying reepithelialization. This cellular chaos results in a raised, inflamed, fragile mass of tissue that serves no healing purpose. In fact, it actively gets in the way. The goal of management? To rebalance the wound environment, calm the inflammation, and restore the conditions that support healthy epithelial closure. Here are some risk factors categorized by cause: mechanical, frequent dressing changes, pressure, or friction. Moisture-related, maceration or excessive exudate. Inflammatory, chronic wounds, biofilms. Device-related, ill-fitted tubes at tracheostomy or gastrostomy sites. Systemic, diabetes, anemia, corticosteroid use. Common sites include peristomal skin, lower limb ulcers, burn wounds, and surgical sites exposed to pressure or moisture. Hypergranulation usually appears as raised, red, spongy tissue. It may resemble a mushroom and bleeds easily due to high vascularity, prevents epithelial cell growth, is often painless unless inflamed, may have clear or no discharge. Differentiating it from infection, granulomas, or neoplasia is crucial. Look for fever, odor, or unusual tissue features that require biopsy. If untreated, hypergranulation can lead to delayed healing due to obstruction of skin closure, increased infection risk, possible need for surgical excision, psychosocial distress in visible areas, chronic recurrence if root causes persist. The first step is to manage what's causing the hypergranulation. For moisture overload, use absorbent or moisture-balancing dressings. For occlusion, switch to semi-permeable dressings or increase dressing changes. Address friction or pressure with repositioning or adjusting devices. Manage low-grade infection using short-term antimicrobials after debridement. Topical interventions include silver nitrate, a common chemical cautery method. Apply with a stick directly to hypergranulated tissue. Repeat 2 to 3 times a week until resolved. Protect surrounding skin to avoid damage. Hypertonic saline dressings. Draw out moisture and reduce tissue. Topical corticosteroids. Reduce inflammation. Use low to medium potency and only for short durations, usually less than 7 days. Topical interventions include silver nitrate, a common chemical cautery method. Apply with a stick directly to hypergranulated tissue. Repeat 2 to 3 times a week until resolved. Protect surrounding skin to avoid damage. Hypertonic saline dressings. Draw out moisture and reduce tissue. Topical corticosteroids. Reduce inflammation. Use low to medium potency and only for short durations, usually less than 7 days. Nurses play a key role in hypergranulation management. Assess tissue regularly, monitor color, height, and wound margins. Choose dressings that balance moisture and avoid occlusion. Monitor pain, especially post-debridement or cautery. Educate patients on healing expectations and care steps. Escalate cases that don't respond or show unusual symptoms. Educate patients and caregivers to keep the wound area clean and dry, avoid touching or picking at raised tissue, report bleeding, pain, or odor. Understand that cautery is a non-surgical, safe approach. Attend follow-ups to assess progress and adjust treatment as needed. Hypergranulation represents a healing imbalance. Too much moisture, pressure, or inflammation blocks wound closure. Timely identification and targeted treatment, such as silver nitrate, moisture control, or debridement, are key. With appropriate nursing care and patient education, hypergranulation can be reversed, restarting the epithelialization process and restoring proper healing.